Usually, when we talk about a medical diagnosis, there's this expectation of mechanical precision.
Oh, yeah, for sure.
Like you break your arm, the x-ray shows that jagged white line, the doctor points right at the film and says, there's the problem.
It's totally binary. It's either broken and not broken.
Right.
And honestly, it's comforting because, well, we naturally want our medical issues to be visible. We want them neatly categorized with a very straightforward fix.
But I mean, step into the world of female pelvic floor dysfunction, and that metaphorical x-ray machine just shatters.
Oh, completely. It's a completely different ballgame.
We are looking at a diagnostic landscape that is incredibly murky, especially when we talk about incontinence or genitourinary syndrome of menopause, which clinicians refer to as GSM.
Right, GSM.
So today, for you listening, we're opening a massive stack of sources to decode this landscape. We've got heavy-hitting clinical guidelines from the American Urogynecologic Society, the British Society of Urogynecology, clinical audits, hospital patient leaflets, and guidance from NICE.
The National Institute for Health and Care Excellence.
Exactly, which sets the clinical standards in the UK.
And that mountain of data, it points to a very specific and frankly vital clinical journey.
Yeah.
We're looking at a space where the initial treatments are often just this frustrating process of trial and error.
Which is why understanding this is so important.
Exactly. It makes understanding the trajectory of care so critical for anyone navigating this.
So our mission for this deep dive today is to decode that specific journey. We want to know, how do doctors objectively define a non-responder to frontline non-surgical devices?
Right.
And exactly when and why should a patient's therapy pivot away from those devices and move toward advanced injectables? Okay, let's unpack this.
Let's do it.
Before we can really grasp what a clinical failure looks like, we have to establish the baseline of what we're actually pivoting from.
Yeah, that makes sense. So the front line for a patient presenting with stress urinary incontinence, or GSM.
Which includes things like severe vaginal atrophy, dryness, painful intercourse.
Right, all of that. The front line for those symptoms is rarely surgery. It's composed of non-surgical devices, and these generally fall into two separate buckets.
Okay, two buckets.
First, you have your physical devices, and second, you have energy-based devices, or EBDs.
Let's break those down. On the physical side, we're talking about things like pessaries or various intravaginal support devices.
Exactly. They are purely structural.
Okay, and on the other side, the energy-based devices involve a lot of complex technology.
Oh, tons of it.
These are your fractional CO2 lasers, ERYAG lasers, radiofrequency devices. The goal with an EBD is to apply targeted thermal energy to the tissue, basically to induce remodeling and stimulate collagen production.
That's the idea, yeah.
Just to help visualize the difference between these two buckets for you listening, a physical device seems like wearing a knee brace for joint support, whereas an energy-based device is more like, I don't know, aerating a lawn.
I like that.
Like creating tiny controlled thermal injuries in the tissue so that it heals back thicker and stronger.
What's fascinating here is how that lawn aeration analogy captures the exact biological intent of the EBDs.
Oh, really?
Yeah, because a physical pessary just mechanically props up the pelvic organs or, supports the urethra.
It's just holding things in place.
Right. It doesn't cure the underlying tissue weakness. It literally just manages the mechanics of gravity. But the EBDs are actively trying to change the tissue architecture itself.
Which is a huge distinction.
It is. And we have to recognize that these energy devices, they fill an absolutely crucial gap in modern medicine, particularly for women who just cannot use estrogen therapy.
Which is a big group. I mean, breast cancer survivors are a major demographic for this.
Huge.
Given that systemic or sometimes even local estrogen can be strictly contraindicated for them.
They are. I mean, a woman going through treatment for estrogen receptor-positive breast cancer, she can experience sudden severe menopausal dyspareunia and vaginal atrophy.
Almost overnight sometimes.
Exactly. And the consensus statement from the American Urogynecologic Society, or AUGS, they note that while we lack high-quality long-term data on these lasers, they do show short-term efficacy for up to 1 year.
So for these patients, lasers offer this vital, non-hormonal lifeline.
A total lifeline, yes.
It is a lifeline, but
Yeah.
looking at our sources, it shows it comes with some heavy regulatory caveats.
Oh, for sure.
Like Back in 2018, the FDA actually issued a safety communication explicitly warning against vague vaginal rejuvenation claims.
Right, that was a big deal.
It turns out this technology is FDA cleared for certain surgical applications, like destroying abnormal cervical tissue.
Yeah.
But the FDA never specifically approved them for these menopausal gynecologic indications.
No, they didn't.
So clinicians are operating in this weird gray area. They see short-term clinical benefits, but they're relying on limited, low-quality evidence for the long-term safety and efficacy.
Yeah, the marketing of these devices vastly outpaced the clinical science.
It always does, doesn't it?
Always. Clinics were advertising lasers as this fountain of youth for the pelvic floor, which basically forced the FDA to step in and remind everyone that, hey, inducing thermal burns in delicate vaginal tissue carries real risks.
Like scarring or chronic pain.
Exactly. And this brings us directly to the crucial pivot point.
Okay.
If a clinician is using a device that offers highly variable relief or purely mechanical support or, relief that just fades after a year, they need a rigorous system to know when to call it quits.
Right, which means defining the non-responder.
Exactly.
If you have a treatment with such variable outcomes, how do clinicians objectively define failure so they can actually move the patient on to better, more advanced therapies?
It can't just be guesswork.
Right. I mean, a non-responder can't just be a patient coming into the office and saying, hey, I feel no different.
Right.
There have to be strict clinical timelines or metrics.
And there are. The process is highly protocol-driven, so let's look at pessaries first. A pessary failure isn't a single conversation where the doctor shrugs and gives up. The clinical parameter for non-response is strictly defined as an inability to achieve a successful fit after 3 distinct attempts.
Wait, why 3 attempts? I mean, why can't a doctor just measure the pelvic floor, like measuring a foot for a shoe, and grab the right size off the shelf?
Because the pelvic floor is a dynamic muscular bowl. It's not a static bone structure like your foot.
Oh, that makes sense.
A patient's prolapse presentation changes based on their posture, how full their bladder is, gravity, all of it.
So it's constantly shifting.
Right. A clinician might start by inserting a simple open ring pessary. The patient stands up, coughs, walks around, and the ring simply falls out because the muscles are too weak to hold the edges.
Wow. Okay, so attempt 1 fails.
Right. So for attempt 2, the clinician pivots to a different mechanical strategy. They might try a Schatz pessary or a Gellhorn.
And those work differently than the ring.
They do. They're bulkier and actually utilize a suction effect against the vaginal apex rather than just relying on the pelvic floor muscles to pinch them in place.
Ah, okay.
If after 3 attempts utilizing different shapes, mechanisms, sizes, the device still falls out or causes severe, unmanageable discomfort.
Then the clinician hits a hard parameter.
Exactly. The patient is officially a non-responder.
Are there any other ways to fail the pessary parameter?
Yeah, alternatively, if a patient does get a good fit, but comparative trials show they lack sustained symptom relief at the 12-month mark compared to simply doing pelvic floor muscle training, they also enter that non-responder category.
Okay, so pessaries have this very physical, structural, and time-bound failure metric.
Yes.
Moving over to the energy-based devices then. If the laser is successfully aerating the lawn, so to speak, how long do clinicians wait to declare that tissue remodeling a failure?
For EBDs, the parameter for non-response is defined by the regression of symptoms before the 1-year mark.
1 year. Got it.
Yeah, the clinical guidelines acknowledge that the optimal interval for long-term treatment with lasers is still completely unknown.
It's wild that we still don't know that.
It really is. So if a patient undergoes a course of laser therapy and their severe vaginal dryness or painful intercourse returns in 8 months, their tissue isn't holding the remodeled architecture.
Right. The lawn isn't growing back right.
Exactly. The therapy isn't considered durable enough to continue blindly.
Then there is the overactive bladder management pathway, or OAB, which really brings those nice guidelines into the picture.
Oh, yes. They lay out extremely specific hurdles for OAB.
Right. What are those hurdles?
Well, for OAB, escalating treatment requires clearing major bureaucratic and clinical hurdles. The non-response parameters are only met when a local multidisciplinary team, or MDT, reviews the case.
Okay, pause. What does an MDT actually look like in practice? Is it just a board of surgeons sitting in a room somewhere?
Not exactly. It's a structured review panel that usually includes urologists, specialized urogynecology nurses, physiotherapists, and sometimes even geriatricians.
Okay, so a lot of different perspectives.
Exactly. It's designed to ensure no single doctor is just throwing advanced treatments at a patient without consensus.
That makes a lot of sense.
Right. The MDT has to confirm that conservative management has categorically failed.
And what does that mean practically?
That means standard OAB medications and electrical nerve stimulation haven't adequately relieved the sudden, uncontrollable urges to urinate.
The sources also highlight a physical parameter for OAB that really caught my eye.
Well, which one?
If a patient literally cannot actively contract their pelvic floor muscles on command, they bypass certain conservative steps entirely.
Yes, exactly.
Because if you can't isolate and squeeze the muscle, biofeedback and physical therapy simply cannot work.
Right.
You can't train a muscle that the brain cannot communicate with.
That is a perfect example of a hard anatomical parameter defining a non-responder. You don't waste 6 months on physical therapy if the neuromuscular connection is absent from the start.
Okay, so we have these strict metrics established. 3 failed fittings for a dynamic pessary, symptom regression under a year for a laser, and a full multidisciplinary team sign-off for an overactive bladder.
Yes, those are the hard lines.
Once those non-responder parameters are met, the next step isn't automatically major surgery.
Thankfully, no.
This triggers the pivot to advanced injectables. Let's start with stress urinary incontinence, or SUI, which is when you leak during a cough or a laugh.
Right. This is the moment the clinical strategy shifts from trying to externally support the urethra with a device to internally augmenting the tissue itself.
Which introduces urethral bulking,
Exactly.
specifically a product called Bulkamid, which is a polyacrylamide hydrogel.
That's the one.
The procedure is wild. It uses a tiny camera inserted into the urethra. The clinician takes a needle and injects this soft, water-based gel into 3 or 4 precise places around the urethral wall.
Yeah, it basically plumps up the tissue from the inside.
Right, creating these little cushions so the tube can seal tightly shut when abdominal pressure spikes. It's essentially adding weather stripping to a drafty door.
Oh, I love that analogy. And the beauty of that weather stripping is that it physically narrows the lumen, which is the actual opening of the tube.
Right.
Because of that, the surrounding sphincter muscles don't have to work nearly as hard to pull a tube completely closed. It just lowers the mechanical threshold required to stay dry.
Here's where it gets really interesting, though. A clinical audit from a district general hospital in our stack traces the sudden, massive surge in popularity for this weather stripping gel back to 2018.
Oh, 2018, a huge year for this.
Right, because that year, the UK government suspended vaginal mesh procedures, specifically the mid-urethral slings that used to be the gold standard surgery for stress incontinence.
The mesh suspension was a seismic shift in urogynecology, truly.
Because the mesh worked well for stopping leaks, right?
The synthetic mesh slings were highly effective at stopping leaks, yes. But a percentage of women experienced catastrophic complications.
Like what?
The mesh could actually erode through the vaginal wall or into the bladder, causing chronic, debilitating pain.
Oh, wow. That's horrific.
It was. So when the regulatory ban hit, surgeons were suddenly left without their primary, minimally invasive tool.
Necessity completely drove the clinical pivot.
Completely.
Clinicians had a massive population of patients who met the non-responder criteria for pessaries and physical therapy, but who now couldn't get a mesh sling.
So the bulking agents just stepped right into that void.
Right, and the metrics for Bulkamid are solid, but they clearly require managing patient expectations. The leaflets state about 70% of people see a meaningful improvement in their symptoms.
Yeah, but the caveat, which is heavily stressed in the patient literature, is that 60% of people require a second treatment to feel it has helped enough.
See, I have to push back on that stat.
Okay, go ahead.
If 60% of patients need a clinician to go back in and inject more gel, isn't that just a delayed non-response?
Yeah.
Like, why not just inject the correct amount the first time?
That's a fair question, but clinically it's viewed as dose titration, not a failure of the modality.
Dose titration.
Yeah. The urethra is an incredibly delicate structure. If a surgeon is overly aggressive and injects too much gel on the first pass trying to get a perfect seal, they risk causing urinary retention.
Oh, meaning the tube swells shut entirely.
Exactly. And then the patient can't empty their bladder at all, which is an emergency.
Yikes. Okay.
So the standard protocol is to undercorrect slightly. They inject a conservative amount, wait a few weeks for the localized swelling to subside and the gel to integrate, and then evaluate.
Okay, that makes sense.
If the door is still drafty, to use your analogy, they just add a tiny bit more weather stripping.
It is definitely better to need a top-up than to be completely blocked.
100%.
Though the hospital leaflets do note that 2 to 10% of patients do experience difficulty emptying their bladder post-injection anyway.
Right.
and they might require a temporary catheter for a few days to drain the urine.
Look, no intervention is completely without risk. But when clinicians and patients weigh a temporary catheter for a few days against the permanent, irreversible risks of surgical mesh erosion,
Oh, yeah.
the bulking agent is a trade-off most are highly willing to navigate.
We've established that bulking agents mechanically block stress leaks by narrowing the tube.
Right.
But what if the non-responder's failure isn't mechanical?
That's the million-dollar question.
What if the failure is due to severe overactive bladder muscles or completely degraded atrophied tissue from GSM? You can't weather strip a spasming muscle.
No, you definitely can't.
And you can't prop up dead tissue. This requires a completely different class of injectable.
Exactly. We shift from structural augmentation to altering the neuromuscular environment and the fundamental biology of the tissue itself.
So let's look at the neuromuscular pivot first, using Botox for overactive bladder.
Right.
Now, for you listening, when most people hear Botox, they immediately picture cosmetic wrinkle reduction, not bladder function.
Absolutely.
Yet the NICE guidelines mandate pivoting to Botox, specifically botulinum toxin type A, when a patient's detrusor muscle is proven to be overactive.
The detrusor is the smooth muscle in the wall of the bladder.
Okay.
In an overactive bladder, this muscle contracts violently and unpredictably, even when the bladder isn't actually full.
Which causes that intense urgency.
Exactly. And just like with the pessary fittings, the parameters for injecting Botox are rigidly controlled. A clinician doesn't just guess the dose here.
Oh, so what's the starting protocol?
NICE dictates starting at exactly 100 units, injected via a cystoscope directly into the detrusor muscle in multiple spots.
And they've evaluated that specific dose within 12 weeks, right?
Yes.
If the symptom relief is adequate, but the effect wears off and lasts for less than 6 months, that specific timeline is the exact parameter authorizing the clinician to escalate the subsequent dose to 200 units.
Right. The Botox physically binds to the nerve endings in the bladder muscle, blocking the release of a neurotransmitter called acetylcholine. It essentially paralyzes a portion of the detrusor, which quiets those violent spasms.
Wait, but isn't the whole point of going to the doctor to stop leaking and regain normal bathroom function?
Well, yes.
Because there is a mandate in the guidelines that before a doctor can even inject the Botox, the patient must explicitly consent to performing clean, intermittent catheterization on themselves at home.
Yes, that is a non-negotiable part of the protocol.
I mean, the Botox might relax the bladder muscles so much that it becomes too weak to push the urine out.
Right.
Meaning the patient has to literally slide a tube up their own urethra multiple times a day to manually drain it.
That's correct.
That feels like trading one massive problem for another. How do patients actually react to that reality in a clinic? Because that sounds terrifying.
I know, it sounds extreme until you understand the profound quality of life calculus a patient with refractory OAB is doing.
How so?
A patient at this stage of the non-responder pathway might be rushing to the bathroom 20 or 30 times a day.
Wow, 20 times.
Or more. They are waking up constantly at night. They can't sit through a movie, they can't ride in a car, or leave their house without mapping out every single public restroom.
Oh, that's debilitating.
It is. The relentless urgency dominates their entire existence. So yes, the risk of Botox is urinary retention.
Right.
But for many patients, the predictable, controlled act of passing a small catheter a few times a day is vastly preferable to the chaotic, constant leakage and urgency of an overactive bladder. It gives them their agency back.
You know, when you frame it as regaining agency over chaos, the trade-off makes total clinical sense.
If we connect this to the bigger picture, it really demonstrates the extreme precision of these clinical pivots.
Yeah.
Botox is a paralyzing agent deployed specifically for an overactive neuromuscular failure.
Right.
But what happens if the issue is degraded, atrophied, painful tissue, like in GSM or like in sclerosis, where the EBD lasers fail to produce a lasting response?
Right. You definitely do not want a paralytic for that.
Exactly. You need a regenerator.
Which brings us to the biological tissue failure pivot. Platelet-rich plasma, or PRP, which in this specific gynecological context is sometimes marketed as the O-shot.
Yes, the OSHA.
The mechanism here relies on taking the patient's own blood, spinning it down in a centrifuge to separate the red blood cells, and isolating the concentrated blood plasma that is absolutely packed with platelets.
Right.
They then inject that golden plasma back into the vaginal and urethral tissue.
It's pretty amazing. It is an autologous treatment, meaning the healing material comes entirely from the patient's own body.
Which eliminates the risk of an allergic rejection, right?
Exactly. You can't be allergic to your own blood. When that concentrated plasma is injected, the platelets degranulate and release powerful growth factors.
Our sources highlight two specific components doing the heavy lifting here.
Okay, let's hear them.
First is platelet factor 4. Second is interleukin 8. Can you break down what those actually do in the tissue for us, like without giving us an entire medical school lecture?
I will do my best. Think of platelet factor 4 as the site foreman at a construction project.
The site foreman.
Its job is to stimulate the initial influx of neutrophils, which are white blood cells that clear out debris and initiate the wound healing cascade.
So it basically sounds the alarm that rebuilding needs to happen right now.
Exactly. Now, interleukin 8 acts as the supply chain manager. It is a chemical signal that promotes angiogenesis, which is the actual biological formation of brand new blood vessels.
So it's building new supply roads to deliver oxygen and nutrients to the starved tissue.
That's exactly it.
Wow. So when vaginal moisturizers fail, and the patient is contraindicated for estrogen, and the fractional CO2 laser only yielded, a few months of relief,
Right.
PRP steps in as this non-hormonal biological pivot.
Yes.
It isn't masking a symptom or mechanically propping anything up. It is literally commanding the local tissue to rebuild its own blood-supplying collagen network.
It perfectly matches the injectable to the mechanism of failure.
That is so elegant.
It really is. A mechanical failure of the sphincter gets the weather stripping of a bulking agent.
Right.
A neuromuscular failure gets the calming paralytic of Botox. And a biological tissue failure gets the autologous regeneration of PRP.
So what does this all mean for you listening? We have tracked a highly complex clinical algorithm today.
A very detailed one, yeah.
We started on the front line with pessaries and energy-based lasers. We learned that being a non-responder isn't a vague feeling.
No, not at all.
It is defined by measurable, strict clinical parameters, like 3 failed structural fittings, symptom regression under a 1-year timeline, or a multidisciplinary team confirming a lack of neuromuscular control.
Right.
And when those parameters are met, the pathway pivots cleanly to advanced injectables designed to fix the specific mode of failure.
If you are navigating this landscape, the overarching takeaway here is that pelvic floor therapy is not a binary choice.
It's not just Kegels or surgery.
Exactly. It's not just doing some Kegels at home versus undergoing major reconstructive surgery. There is a deeply structured, scientifically backed middle ground.
Which is so empowering to know.
The clinical pathways are designed to adapt and escalate precisely when your body fails to respond to initial treatments.
It proves that if you feel stuck, the medical community hasn't run out of options. You have simply met the criteria for the next targeted step in the algorithm.
And, that algorithm is constantly evolving, which actually brings up a fascinating forward-looking question based on the mechanisms we've analyzed today.
Oh, what's that?
Well, we know that energy-based devices work by inducing controlled thermal microtrauma to trigger tissue remodeling, right?
Right, aerating the lawn.
Exactly. We also know that platelet-rich plasma relies on injecting concentrated biological growth factors to supercharge the healing process.
The foreman and the supply chain manager.
You've got it. So clinicians are now asking, what happens when we start stacking these modalities?
Oh, wait. Using them both at the same time.
Exactly. Imagine a synchronized protocol where a laser is used to intentionally open and prep the tissue with microtrauma, immediately followed by a PRP injection to flood that exact thermal zone with interleukin 8 and platelet factor 4.
Wow, so you create the injury and instantly provide the ultimate healing materials.
Right. The future of pelvic health might not just be finding new isolated treatments, but intentionally combining thermal injury with autologous regeneration to completely redefine what it means to heal.